Well, I appreciate the opportunity to speak here. I was invited and jump on the chance. Like a good orthopedic surgeon, I need visual aids to actually function up here. So I'm going to put a few slides together. So our office is based in Stillwater. We're sort of the East Metro area in western Wisconsin. So as was mentioned earlier, we're somewhat of a rarity or dying breed in that we're still an independent practice, physician-owned group, and we're hoping to remain that way. So I think that's part of the reason I was invited, to give my perspective sort of from that context as a independent practitioner. Just a few background points I think are worth making, and then there are a few questions that we wanted to about 5 or 6 questions we were all going to answer. But one of the questions that I've asked myself, or that often is asked, is what comes first? Is it your business or your patients? And obviously from a conceptual, from a philosophical, humanitarian standpoint, we all want to say it's our patients. But when you really think about it, in reality, if you don't protect your business, and your business goes under, you're not there to protect your patients or to care for your patients. And so ultimately, you have to really keep that in mind, that yes, it's good to philosophically say that the patients come first, and that's what we have to do. But ultimately, you have to also make sure your staff are there to provide the care that you need to provide. Your infrastructure is there. You're there to be able to still provide that care for the patient. So we can't forget that there is still a business side to medicine, and we have to, unfortunately or fortunately, protect that. There are a few guarantees in life, and unfortunately one of those is death. And so as far as our metrics go, there's one metric that we can't change. We all end up the same place. However, we can spend limitless amounts of money on our health care during our birth to our death. And so one we can change, one we can't. And so obviously we need to focus on the limitless amount of money that we can spend on health care. In America, we obviously are consumer driven. We like to spend money. We like to have what we want it now, and we want to get it now, and there shouldn't be anything in our way. But unfortunately, that probably needs to change. Different statistics have shown that doctors' share of that limitless amount of money is perhaps anywhere between about 7 and 11% of the healthcare dollar. So as doctors, if we could somehow all work for free, we would only save 7 to 11% of the healthcare dollar in the U.S., which unfortunately would put a small dent in the whole system. Whereas administrative costs are about 20 to 30%. Again, a lot of different estimates are there. Unfortunately, I think in the ACA there are some provisions to try to reduce the load, try to streamline, again, coverage, so there's not as much confusion on patients coming in. There are efforts to try to reduce the amount of administrative load that's occurring. But in reality, one of my concerns would be with these ACOs and other entities that are being developed, there's going to be more administration. There's going to be more paperwork, more go-betweens between the patient and the doctor or whatever the provider is. So that is one of the major concerns that I have, and I think we should all have. Typical practice overhead in a private practice is about 50%. So for every dollar we collect, about 50% goes to pay everything else, from rent to ancillary staff to everything else. On the upside, if you want to try to put a rosy spin on things, you can say that the healthcare dollars, at least they circulate in the U.S., you can look at it as a redistribution of wealth or circulation of money. It doesn't go overseas usually for most healthcare. So if you want to try to look at it in a positive light, you can look at it that way. And in reality, it's impossible to achieve all of these goals without sacrifice. Our politicians want to promote this, that we can do all these things together, but unfortunately there's sacrifice involved. It's either you or I, it's the patients, it's probably going to be everyone. We can't reduce costs without either reimbursing less or consuming less, or probably both. We can't improve care and quality without probably putting a little effort into it. We need most likely transparency. We need a little better transparency so patients can see what they're getting, and they can see that in a transparent and understandable way. And how do we go about expanding coverage? How can we provide cover for all? And if we're going to provide basic care for everyone, to what extent is that basic care going to be covered? And I think Manny probably has a good handle on that, as he mentioned earlier. But you really wonder where you have to draw that line, and that again becomes a philosophical question as well as just a practical question from a monetary standpoint. A recent study in the orthopedic literature again really highlighted sort of this patient disconnect. They did this actually for cardiology procedures, appendectomy, a bunch of other procedures, but in my world, total knee replacement. Basically, they did a study of patients that were undergoing total knee replacement and asked them, what do you think your surgeon should get paid? And then the second question, what do you think they actually get paid? And then at the end, they told them what the real number was. And keep in mind, the payment for a total knee replacement to the surgeon involves the surgery, taking care of the patient in the hospital and 90 days of postoperative care. So on average, physicians, and I don't know in what world this happens, but patients thought that a surgeon should get paid $13,000 for a knee replacement surgery. That was sort of, probably just a bit of an exaggeration, obviously. And then they thought, well, in reality, they probably get paid about $7,000. But then the Medicare statistics show that, on average, you get paid about $1,400. And again, that goes to pay the surgeon, but also pay the overhead for that surgeon's office, et cetera. So there's a huge disconnect, about a tenfold disconnect in what patients think a surgeon or a doctor is perhaps getting paid for whatever procedure they're consuming, and they have no idea. And that is a serious problem. We can't get healthcare prices down or expenditures down without trying to bring that gap together. So, just trying to address the questions that we're sort of charged with addressing. One of the questions I had was, how am I as an individual, how is my group as a practice preparing for what's happening? Well, we're in a unique position in that we're an independent group. We have affiliations with about 12 different hospitals. We cover a very large geographic area. We have affiliations with many groups, private primary care groups, health systems, including Health Partners, Fairview, Allina, Health East, and we have been in practice as a group for about 35 plus years. Fortunately, we've, over those years, been consistently rated as high quality and low cost, and so we've positioned ourselves well. Again, do you believe those statistics? Because they're measuring questionable metrics, but we can claim that we are high quality and low cost based on some published results. The hospital that we primarily service has been rated as the #1 orthopedic hospital in the state for actually a few years running, and so again, we can use that as something to fall back on, and at least conceptually think that we're going to be positioned well to stay independent and provide care and be a part of an ACO if it comes up, because again, that's what an ACO wants, is someone who provides high quality and low cost. Is that reality? I don't know. So the answer to how we are preparing is basically we're going to try and keep doing what we're doing. Really try, as all of you do, try to provide high quality care at the lowest cost possible. What are our greatest opportunities? Really, it sort of leads back to the first question. Our greatest opportunity is hopefully just to keep doing what we're doing. And hopefully as further metrics come out, as further statistics come out, as further outcome measures come out, we will actually be able to substantiate and prove that, yes, we are doing what we say we're doing. However, you never know. Yeah, statistics can be fickle. It's the lies, damn lies, and statistics phrase. You never know which end you're going to come out of. You're going to come out on the top end or bottom end of the whole cost and quality curve, because you just don't know what's being measured and how accurate it actually is. But our greatest opportunity really is to keep doing what we're doing and hopefully providing high quality and low cost care. Our greatest threat is really, as was mentioned, constant pressure from larger groups, the systems and hospitals. There's constant pressure for us to be absorbed by someone else. We hopefully, again, are in a unique position because we provide rural care, we provide suburban care, so we provide a large geographic area where we're not as contained into a small area, and so we can stay independent in that regard. Other threats are the administrative burden. Meaningful use, again, is not part of the ACA, but it's a huge administrative burden. Portions of the ACA and ACOs coming up are going to provide more administrative burden, so that 50% overhead that we have is, I'm sure, going to slowly climb and create more financial stresses for us. Biggest threats, again, loss of independence, goes back to #1. And then just further regulation. We're constantly having to ask patients questions about their past medical history, when they last had a mammogram, things like that. Again, not related to the ACA, but related to other regulations. Now the ACA, the concern is, are there going to be further regulations, because so much is still undefined, that we're going to have to be collecting this data and not seeing patients and doing the things that we need to do. We're going to spend more time doing administrative, technical things, filling out boxes and filling out papers that need to be filled out. The missed opportunities, I think, tort reform in some manner is a hot button topic. One of the examples I have, I subspecialize in upper extremities, so I see a lot of patients with wrist ganglions, cysts, bumps on the wrist. I can tell them about 99.99% certainty it's not cancer. However, 0.01%, maybe somehow it could be something weird. So if a patient's sitting there and they want to have an MRI, And I'm sitting there and thinking, well, it'll cover my rear, I guess, if we get an MRI. And throw in it, maybe I have an MRI scanner that I'm financially incentivized to use. I've got 3 different things that are potentially pushing me to getting that MRI. There's nothing to keep me from doing that other than either having a long discussion with the patient and talking them off the cliff that it's going to be okay, or just taking the easy road and getting the MRI. One of the easiest ways to change that, though, is that the patient actually has to shell out $700, $1,000, $1,500, whatever it takes to pay for an MRI. If they have that financial hit that they have to take, they might think twice or 3 times about it. Most of us would probably go ahead and skip the MRI because it's not necessary. So again, that's just a really day-to-day example that I see. And again, that's not really tort reform, but that's just a way of bringing the whole thing around because there are so many different pieces of this puzzle that come together. Restricting, keeping orthopedists from having MRI scanners or keeping doctors from having MRI scanners or different ancillary revenue streams isn't the way to necessarily curb that. It's getting the patient more in touch with actual payment. The concern is that this is going to create more administrative burden rather than less. Again, one of the biggest criticisms of the U.S. healthcare system is that we have high administrative costs and a lot of money goes to administration. I don't see that this is necessarily going to reduce that. And so unfortunately, one of the biggest problems we have in our healthcare system is high administrative costs. And I think, unfortunately, this is not going to reduce that at all. And I think, again, instead of giving the responsibility to the patient, we continue to sort of perpetuate that middleman mentality where there's a doctor and there's a patient and there's an insurance company or some entity in between that is providing or paying for these services that they're receiving, and they don't have really much skin in the game. So I think we need to probably creatively figure out a way to bring that together. So advice to others, again, these are all, anybody could write this slide, provide high quality and low cost care. I think we need to involve the patients in the decision making, and unfortunately, time is money. Sometimes, again, as in the example of the MRI scan, spending an extra 15 minutes reassuring a patient that it's going to be okay, with the thought in the back of my head of thinking, if I'm reassuring this patient that it's okay, and yet there's a 0.01% chance that somehow I'm wrong and I'm going to be sued, it's a tough discussion to have. And so we really need to involve patients in the decision-making process. And we need to educate patients in regard to the cost. I think the best way to educate them is, unfortunately, for them to feel it as well. It's not often that any of you go to the restaurant without a menu that has prices on it. It would be nice if that was the way it was, but it's never that way. And I think you have to remain flexible and ready to adapt. I think the whole Darwinism theory of staying adaptable and ready and flexible, because, again, if this gets struck down, we have to be flexible and get ready to move in a different direction. That's it. Thanks.